Assalamu alaikum wa rahmatullah. This is a gastroenterology chapter about GIT. GIT starts with the mouth cavity ending by anus, okay? Having here the salivary glands, parotid, submandibular, and sublingual glands, having here the esophagus ending in the stomach. Then so we have small and large intestine, the liver, gallbladder, and pancreas. Nerve supply of small intestine, involve the enteric nervous system. Enteric nervous system that is formed by axis between the brain and the GIT. It's called gut-brain axis with nerve fibers supplying the intestine. We having here two plexuses called the myenteric and submucosal plexuses. These plexuses of nerves control the peristalsis, control enzyme secretion. Dysfunction of these plexuses can be associated with functional disorders of the GIT, resulting in vomiting, constipation, or diarrhea. About the gut or gut-associated lymphoid tissue, to know that if this is the brush border of small intestine, sometimes exposure to certain microbes or food agents associated with inappropriate immune response. Okay, that will result in activation of immune cells here involved in the Peyer's patch that will be drained to the mesenteric lymph nodes and then to thoracic ducts, finally to peripheral circulation. So we have a lymphoid tissue, okay, here in the intestinal wall that can be associated with certain pathologies in the GIT. Gut motility controlled by a sum of factors, including the intrinsic myogenic activity of the intestinal wall, what's called the interstitial cells of Kagel, and autonomic and enteric nervous system we have just mentioned, and also gastrointestinal hormones. Interplay between these factors result in the normal gut motility, where we have a balance between excitatory stimuli and inhibitory stimuli to the gut motility to allow for proper swallowing, proper digestion and absorption of the food particles. So if we see here in the esophagus, where we have alternative areas of contractions and areas of relaxation to allow swallowing and the movement of the food bolus appropriately. Sometimes motility disorders are present due to pathology in one of or more of these factors. Motility disorders or gut dysmotility is quite common, associated with vomiting, abdominal pain, recurrent obstruction, constipation, or diarrhea. For example, we have GIRD, gastroesophageal reflux disease, pyloric stenosis, and Hirschsprung disease. These are all motility disorders of the gut. Starting with vomiting. Vomiting, we need to differentiate between the simple vomiting and regurgitation, which is very common in the neonatal and infancy period, where there is simple regurg of small amounts of milk, usually after feeding, okay? And to differentiate it from significant vomiting, okay, that would require workup and intervention. We have red flag signs for vomiting in childhood. When vomiting is bile stained, this is significant. This indicates we have a serious problem, usually in the form of intestinal obstruction. When we have obstruction in the gut distal to the insertion of ampulla of water in the second part of the duodenum, it will become bile stained. Okay, so bile stained vomitus is always significant. When vomitus is associated with hematemesis, okay, this is significant, may indicate peptic ulcer disease, may indicate bleeding diathesis or other significant abnormality. Also, when vomiting is projectile, okay, we may think also of intestinal obstruction, including pyloric stenosis, duodenal stenosis or atresia or others. Vomiting at the end of paroxysmal coughing, okay, this usually diagnostic for the whooping cough or pertussis as a bacterial infection. When we have abdominal tenderness or abdominal pain, okay, on movement may suggest we have intestinal obstruction. When we have abdominal distension, when we have hepatosplenomegaly associated with the vomiting, usually in infancy period, you should think of inborn error of metabolism. When you have persistent vomiting associated with failure to thrive and organomegaly in the form of hepatomegaly, you should think of inborn error of metabolism, or it may be a liver disease. When we have blood in stools associated with the vomitus, you should think of, for example, bacterial gastroenteritis or intussusception, a serious complication. When we have severe dehydration and shock associated with vomitus, it's always significant. Bulging, fontanelle, or seizures with vomitus will suggest we have increased intracranial pressure. And when we have faltering growth, okay, failure to thrive means this vomiting is significant. So what is the differential diagnosis of a vomiting in an infant? Okay, usually this is a differential diagnosis of GERD or gastroesophageal reflux disease. So the first possibility of an infant presenting to you with vomiting, and the most common presentation is for the gastroesophageal reflux. Okay, others include feeding problems, maybe overfeeding, maybe too frequent feeding will be associated with vomitus in an infant. Vomitus can be related to infections like gastroenteritis, otitis media, renal tract infection, or it can be a food allergy or food intolerance simply, which is quite common also in this age period in the form of cow milk allergy and the celiac disease. Eosinophilic esophagitis is an entity associated with persistent vomiting, will be discussed separately. Intestinal obstruction, Hirschsprung disease, also in newborn period or infancy period, resulting in functional intestinal obstruction, will be associated with vomiting. Intestinal dysmotility, okay, for example, in achalasia, we will discuss it now, also will be associated with vomiting. Inborn error of metabolism, do not miss an infant with persistent vomiting for no obvious cause, associated with faltering growth and hepatomegaly. Congenital adrenal hyperplasia associated with infancy due to cortisol deficiency, and renal failure, uremia, will be associated with persistent vomiting. While in a child who is presenting, older child presenting with vomiting, you would think first of gastroenteritis associated with vomiting and diarrhea, infections including pyelonephritis, meningitis, and septicemia, peptic ulcer disease and helicobacter infection can be the cause of vomiting in older child. Appendicitis, okay, intestinal dysmotility, again, migraine can be associated with vomiting. Raised intracranial pressure, renal failure, and uremia. Diabetic ketoacidosis can present just with vomiting and abdominal pain. You should measure random blood sugar in all these patients. Cyclic vomiting syndrome will be discussed separately. Eating disorders like bulimia and anorexia nervosa frequently associated with vomiting in older child. Sometimes psychological, when all examination and labs are normal and no associated cause. Sometimes taking history about social circumstances may reveal psychological cause for the vomiting, including anxiety and irritable bowel syndrome. Starting with the common presentation, which is the gastroesophageal reflux, which means we have involuntary passage or reflux of the gastric content back to the esophagus. Okay, this is not normal. It is extremely common in infancy, where we have inappropriate relaxation of lower esophageal sphincter related to functional immaturity of this sphincter. Okay, so resulting in reflux of gastric content back to the esophagus, associated with gastric acid, which will result in irritation of esophageal mucosa and may end by chronic esophagitis. So gastroesophageal reflux is quite common and usually resolved by 12 months of age on maturation of the sphincter. When the reflux is significant, it's called gastroesophageal reflux disease. In this disease, there is faltering growth, okay, when there is failure to gain weight appropriately according to the age. when we have excessive hiccups, dysphagia, and when we have esophagitis manifested by hematemesis, okay, discomfort on feedings, heartburn, and due to the chronic blood loss, it will result in iron deficiency anemia. Recurrent aspiration can occur, resulting in recurrent aspiration pneumonia, cough, and wheeze. And it's important, the differential diagnosis for wheezy chest in infancy and the childhood is the reflux. Sometimes it is indolent and not obvious in the form of vomiting, so should be searched for. Okay, apnea in preterm infants also can be presentation of reflux. Okay, in most extreme cases, Sandy Fire syndrome, where we have arching of the back like that, with this tonic neck posturing also coinciding with the reflux of gastric contents into the esophagus, is characteristic for GERD. Another presentation is the apparent life-threatening events. Okay, when we have recurrent cyanotic episodes, a child can be cyanosed and completely limp, even losing consciousness. So it's called the apparent life-threatening events related to reflux events. Usually, GERD is a clinical diagnosis, okay, taking history and examination. To confirm your diagnosis, the gold standard is the 24-hour esophageal pH monitoring, where a tube is posed here and using a probe to measure the pH in the upper and the lower esophagus to get the acid reflux index, which means percentage of time with pH less than 4. Okay, so this quantifies the duration all over 24 hours where pH in the esophagus is acidic, okay, is below 4 due to the reflux of gastric acid into the esophagus. Based on this index, severity of reflux can be graded into mild, moderate, or severe. Less common to use contrast studies to diagnose reflux, okay, as it is less specific and sensitive, and its advantage may be in picking up anatomical abnormalities that can be associated with reflux. This is a contrast study. It's called barium swallow, where reflux of the gastric content back to the esophagus is seen in the X-ray. This X-ray shows that with long-standing reflux, strictures in the esophagus occurred here. Another investigation can be used is the milk scan. In milk scan, it is a nuclear study using technetium-99 radioscintigraphy, where milk is used, okay, to diagnose the reflux, okay, of gastric content into the esophagus. It has an advantage over the contrast study. It can diagnose acid or alkali reflux after a physiological meal, which is the milk. So also it is assess the gastric emptying to diagnose prolonged or delayed gastric emptying. 24-hour film to look for evidence of aspiration. You can see here that gastric content undergone reflux here back to the esophagus. Also, this can be quantified over 24 hours to grade the severity of reflux disease. Okay, so we have done 24 esophageal pH monitoring. This is the gold standard, but it cannot diagnose the alkali reflux. So milk scan is used to diagnose both acid and milk and the alkali reflux using a physiological meal, which is the milk. Finally, in severe undiagnosed cases, endoscopy and biopsies can be taken to diagnose maybe excess eosinophilic infiltrates in the esophagus suggest we have cow milk allergy or the entity of esophageal esophagitis. So sometimes endoscopy done in cases of persistent vomiting associated with failure to thrive to diagnose both reflux disease and to get differential diagnosis may diagnose a case of cow milk allergy or eosinophilic esophagitis where there is eosinophilic infiltrates in the biopsy. Finally, manometry can be used to get the differential diagnosis. We may find achalasia rather than reflux as the cause of the persistent vomiting. Treatment of reflux usually takes a step-up approach, starting with lifestyle measures in a trial to relieve the reflux and lessen the symptoms till spontaneous resolution can occur usually by 12 months of age. These lifestyle measures include explanation of the condition to the parents and reassurance, reviewing the feeding posture and asking for keeping the child in upright or the infant in upright posture while feeding. And even after feeding with about 10 to 20 minutes to guard against reflux of gastric content, review of feeding practice to avoid too frequent feed and to avoid large volume feeds which increase the risk of reflux, use of feed thickeners and anti-reflux formulas also can be tried, okay, and even 2 to 4 weeks trial of extensively hydrolyzed formula, okay. This can be therapeutic trial to exclude cases like cow milk allergy and eosinophilic esophagitis, where exclusion okay, of milk, cow milk, and the use of hydrolyzed formula like breast meal, like Nucate, can sometimes give relief to the reflux disease. Okay. So starting with the lifestyle measures as a management for the condition, compound allignates like Gaviscon can be used to form a lining for the gastric wall to lessen the effects of gastric acid, and then the use of acid suppression starting with the H2 blockers like oral ranitidine, okay, and if no response on oral ranitidine, proton pump inhibitors as oral omeprazole can be used. The use of prokinetic medication usually debatable. Some say it should be discouraged and it has no benefit, even have significant side effects like domperidone and metoclopramide. Others say we can use prokinetic medications safe like erythromycin and gastric. In cases that is not responsive to the lifestyle measures, not responsive to the step-up approach using these medications, you should exclude condition like cow milk allergy. Finally, in severe cases, especially in cases with neurological disorders like cerebral palsy, for example, the condition is much severe, and the need for surgical intervention is usually needed in the form of a Nissen fundoplication. In this procedure, a part of the stomach fundus, okay, is wrapped around the lower esophageal sphincter and the lower esophageal part to reduce reflux of gastric content. This can be done by laparoscopy. So what is the differential diagnosis of reflux esophagitis? Okay, so again, when we have reflux of gastric content that contains the gastric HCl back to the esophagus, this will result in inflammation of the esophageal mucosa, presenting with manifestations like chest pain, heartburn, vomiting, failure to thrive, okay, dysphagia. Okay, so this has a differential diagnosis. Cow milk allergy esophagitis should be excluded, maybe using serology or maybe using exclusion diet. Eosinophilic esophagitis, which will be diagnosed on basis of histological findings of biopsy specimens taken by endoscopy. Candidal esophagitis may be in cases immune compromised. Chemical esophagitis due to caustic ingestion can be a cause. Achalasia, it will be discussed now. It will result in esophagitis and persistent vomiting. It is a dysmotility of the gut. And finally, Crohn's disease can be associated with reflux esophagitis. So what is eosinophilic esophagitis? That present mainly with dysphagia. When we have a child who has atopic disorder, and atopy means we have IgE-mediated immune response presenting with allergic rhinitis, allergic conjunctivitis, bronchial asthma, and even eczema. Okay, so when we have another atopic condition in a child or a family history of atopic disease, maybe in the parents or other siblings, this increase the possibility of eosinophilic esophagitis to be the cause of vomiting and failure to gain weight. Okay, the diagnosis is based on endoscopic findings with the characteristic histology. The treatment for this condition will be in the form of dietary elimination. Okay, in a trial, recurrent trial to eliminate suggested foods that are suggested to be triggers for this inappropriate immunological response. So it can be considered a form of atopy. Inhaled corticosteroids can be used in a swallowed fashion to treat this condition. Anti-inflammatory and immune suppressant can be used in the most severe cases. So what is achalasia? Achalasia is a motility disorder of the gut where we have failure of relaxation of the lower esophageal sphincter, okay, in response to swallowing. So normally when we swallow solids or liquids, there is a relaxation of the lower esophageal sphincter to allow food particles and the liquids to reach the stomach, okay. Failure of relaxation of this sphincter is called achalasia. This motility disorder that present mainly with dysphagia, okay, with regurgitation, okay, with due to aspiration, cough and chest discomfort, or even chest infections can present. So in those cases, usually contrast study in the form of barium swallow is used for diagnosis. Doing barium swallow will show this characteristic appearance of fluid level here in the lower part of the esophagus. To confirm the diagnosis, manometry is used to measure the pressure here in the sphincter, and the management will be in the form of either balloon dilatation, which can be on recurrent basis, or a surgical intervention in the form of myotomy to divide this muscle, okay, to allow its relaxation. And finally, botulinum toxin can produce temporary relief of this condition. So again, what's the differential diagnosis of dysphagia? Okay, when we have dysphagia in a child, you should think number one of neuromuscular disease, okay, including cerebral palsy. Usually this is a common cause in childhood period with cerebral palsy associated with pseudopulbar palsy. Palsy to cranial nerves 9, 11, 9, 10 will be associated with inappropriate and difficulty swallowing and dysphagia associated with drooling of saliva and so on. Other causes include achalasia. You should think of it. Scleroderma, that is immunological condition associated with sclerosis and the stiffness of skin and mucous membrane, will be discussed in chapter of rheumatology. Severe gastroesophageal reflux can end by dysphagia. And finally, eosinophilic esophagitis, you should think of it. Now about the congenital anomalies of the gut, starting with esophageal atresia. Esophageal atresia is a condition frequently seen in the neonatal practice. Once you have a child with or a baby with esophageal atresia, please think of the Bacterial sequence, where we have a collection of congenital anomalies, including vertebral, anal, cardiac, tracheoesophageal, renal, and limb anomalies. Finding one anomaly urge you to search for the other anomalies. When we have atresia here to the esophagus, means the child is not swallowing amniotic fluid during the intrauterine life, which is normal. So this will manifest antenatally with polyhydramnios. Okay, so the condition can be diagnosed antenatally or can be presented postnatally with frothy oral secretions. This is very important common sign with choking and the cyanosis on feeding. If the child is not diagnosed and he started to feed from his mother, the atresia will result in regurgitation of milk back to the trachea, presented with choking and cyanosis. In this condition, immediate surgical consultation is required to undergo surgical correction after resuscitation of the child. We have different types of the tracheoesophageal atresia, with the most common type, this type, where we have esophageal atresia associated with distal tracheoesophageal fistula. Okay, so we have atresia here and fistula here. This is the most common type of esophageal atresia, constituting 80-60% of cases. Other less common conditions include this, for example, two pouches of esophagus not connected to the trachea, or this where we have proximal fistula between esophagus and trachea with distal blind pouch like that. This is another entity, just 1% of cases with both parts of esophagus connected to the with fistulae to the trachea. Finally, the H-shaped. This is the H-shaped tracheoesophageal fistula, where the esophagus is in a continuity but connected to the trachea, and here a membrane like structure here separating both. This diagnosis can be delayed, okay, and just present with recurrent attacks of choking during feeding, or can be present with recurrent aspiration pneumonia. And the diagnosis for this condition usually need either endoscopy or bronchoscopy to diagnose the presence of this membrane in between trachea and esophagus. This is a very famous picture of our X-ray showing the recoiling of the nasogastric tube inserted here in a case of esophageal atresia. Okay, so this is very important X-ray. Other anomalies of gut other than esophageal atresia include we may have duodenal atresia, for example, and this gives us the characteristic double bubble sign here in this abdominal X-ray. Don't miss it. In these cases with atresia that is distal to the insertion of ampulla of water in the second part of the duodenum, will present with delayed vomiting, okay, till after feeding, and this vomiting will be bilious, will be bile stained. This is very important. Down syndrome usually associated with risk for esophageal and duodenal atresia. Another congenital anomaly in the gut include the malrotation, where we have failure of the normal complete rotation of the gut during the intrauterine life. So normally during the intrauterine life, the gut is lying on one side like that, okay, and normally it undergoes rotation, okay, okay, about 270 degrees to fill the abdominal cavity. Failure of this normal rotation result in anomaly called malrotation, where we have here intestinal loops located on the right side of the abdomen. Usually have these fibrous bands that's called Ladd's bands. These Ladd's band can compress the duodenum like that, presenting with intestinal obstruction and the duodenal obstruction. Most common cause of malrotation associated with high up cecum and appendix like that, and due to having a narrow-based mesentery of the intestine, which is the peritoneal covering of the intestine that fixed to the posterior abdominal wall. Due to this anomaly become narrow-based, okay, and this increased risk of intestinal loops to rotate around this narrow-based mesentery or omentum. This rotation can end by volvulus, resulting in abdominal in intestinal obstruction, okay, and interruption of the blood supply will end by venous engorgement and ischemia of the intestinal loop. This can be fatal, ending by intestinal strangulation, perforation, and death. Okay, so we have obstruction of the duodenum can occur because of Ladd's band. Volvulus also is a complication due to the unfixed mid-gut loop on its narrow rotation of the loop on its narrow base with ensuing intestinal ischemia. Contrast study can diagnose malrotation. Here we can see this is intestinal loop located on one side of the abdomen, and this is the cecum lying high up in the abdominal cavity. Okay, so contrast study can diagnose this anomaly. Treatment for such anomalies will be surgical. Another anomaly is called gastroschisis. We have two types of abdominal wall defects. Defects in the anterior abdominal wall. We have gastroschisis and omphalocele. Usually you asked about the difference between both. In gastroschisis we have a small defect, okay, in abdominal wall, usually on one side of the umbilicus, usually on the right side, like that. We have normal umbilicus, normal insertion of the umbilical cord, and beside it we have a small defect in the anterior abdominal wall through which intestinal loops project like that. We have no covering membrane here for the intestinal loops. This is emergency. Once infant or a newborn is delivered, the surgical consultation should be done, and the infant's lower body should be placed in a sterile plastic bag, okay, with a large bore nasogastric tube to be inserted to limit the passage of air into the bowel. So it is a surgical emergency, okay. The other abdominal wall defect is the omphalocele, where the defect here in the umbilical opening itself, okay. So it is a defect in the umbilicus with herniation of abdominal contents. Here contents are covered by a sac formed by the umbilical cord, okay. Do not miss Prader-Willi syndrome that has omphalocele as one of its major presenting criteria, plus the overgrowth and the macrosomia. Immediate postnatal, also this is a surgical emergency. Postnatal management including a nasogastric tube insertion and surgical correction.